Unicast is brought to you by SUMA, the voice of Saskatchewan's urban municipalities. SUMA is proud to represent the urban communities that over 80% of Saskatchewan residents call home. Unicast discusses issues related to local governance and municipal leadership like best practices, education, reconciliation, resources, and more. In Season 8, we're focusing on SUMA's key advocacy initiatives. This episode explores the challenges of healthcare access in small communities, the broader social impacts, and some of the specific barriers to accessing mental health services. Local governments are experiencing the ripple effects of widespread mental health and addictions challenges, putting increased stress on municipal services. In this episode, Dr. Nuelle Novik, Associate Professor in the Faculty of Social Work at the University of Regina and a researcher with the Saskatchewan Population Health and Evaluation Research Unit, Dave Nelson, Senior Program Consultant with the Canadian Mental Health Association, and Rebecca Rackow, Assistant Executive Director with the Canadian Mental Health Association, sit down with Kerri Martin, Advocacy Advisor with SUMA, to discuss the impact of limited healthcare services in small communities. Dr. Novik has practiced as a social worker in the areas of healthcare, mental health care, and community development in Saskatchewan, and spent 6 years as coordinator of the social work program at Aurora College in the Northwest Territories. During that time, she was involved in leadership positions with the Association of Social Workers in Northern Canada and the Canadian Association of Social Workers. She continues to practice part-time as a therapist with a community-based counseling agency. Her research interests include rural and remote health and mental health, older adults, dementia and dementia care, and end-of-life care. Dave Nelson has held many different positions, including the executive director of both the Regina branch and the Saskatchewan division of the Canadian Mental Health Association. Dave was part of the task team that created SAID and has been a big part of public policy development in Saskatchewan around mental health issues. Rebecca Rackow started with the Canadian Mental Health Association as a practicum student, and currently her portfolio includes program development, youth programming, research department, advocacy, and training programs. Conducting today's interview is Kerri Martin, Advocacy Advisor with SUMA, where she advocates for members on health, mental health, and supporting various related initiatives.
Welcome, Dr. Novik, Dave, and Rebecca. It's a pleasure to be speaking with you today.
Good. Thank you.
Thank you.
Thank you so much. And thanks so much for the invitation to participate in this discussion. I've known my co-presenters for a long time, and it's wonderful to be able to engage in this kind of discussion with them.
We are going to start today's conversation with some discussion on the current state of healthcare in small communities. Dr. Novik, can you explain the background of your project, the current state of healthcare in rural Saskatchewan from April 2024, as well as the purpose and goals of the project?
So in terms of background, as you indicated, we released the final report for this project in April of 2024. So we're coming on a year now. There's still a lot of interest in the report and the data that we collected. So that's really positive because that sort of ties into what our original goal was for the project. So as we know, there have been a number of changes to healthcare delivery across the province. In recent years, that's sort of been the trend. We certainly hear more in the media about how these changes are impacting urban settings. And one of the things that we noticed as researchers for sure, and also agreed with colleagues on this from other sectors of healthcare, was that we're not always hearing about the issues and how they're impacting healthcare delivery in rural and remote parts of the province. So that was something that we were really interested in taking a look at. So what we were trying to do with the project was to examine this current landscape. So what's happening right now in terms of rural healthcare delivery in Saskatchewan. And the goal of the project, and this ties back to me saying, there's still interest in the results, which is what we're happy about. But the goal of the project was to try to initiate a public dialogue about future policy directions, so things that could be done that can hopefully protect and preserve access to quality healthcare services for Saskatchewan's rural residents in particular. So again, we hear an awful lot about, physicians and nurses in particular, and that makes sense because obviously those are professions that are key when we're talking about healthcare. But these impacts also are really having influence over other professions as well, right? So rural healthcare workers and other occupations. So continuing care aides, food service workers, admin support folks largely who are employed, through CUPE. So this is part of what we were looking at or wanting to look at in terms of the project itself. We used 4 specific research methods to gather this information. So we started with a really in-depth literature review. So we were looking at, okay, what kinds of government reports can we have access to? What kind of information can we find on websites? What kinds of academic research articles are available? And that's pretty limited, needless to say. We were also looking at other publicly available data. So certainly news reports, stories in various newspapers across the province as well. So we started with gathering that information from that literature review. And the whole idea was that would then really frame, how we decided to move forward with the other sort of approaches to gathering data. So we started with the literature review. We had access to service disruption data. So that was really significant because that allowed us to get a much clearer idea of the parts of the province. And again, we were focusing primarily on rural and remote areas. So that allowed us to really see what parts of the province were experiencing longer service disruptions and were experiencing service disruptions more often. So when we're talking about service disruptions, of course, we're talking about emergency room closures, but we're also talking about the availability of radiology. We're talking about lab availability and all of those aspects that are really key to healthcare delivery. So we had access to that data. We did an analysis of that. We then interviewed a number of key informants. So these are folks from within the system. And, we asked them about their experiences with changes and their experiences currently with healthcare in rural Saskatchewan. And then we pulled all of that information together and we held a World Cafe event. And we did that virtually and really made an effort to try and bring in as many folks as possible. So not just some of these frontline workers. We invited physicians. We invited folks from the Ministry of Health. We invited folks from the Saskatchewan Health Authority. We invited folks from the unions. So the goal was to be able to present this data and information that we had pulled together and talk about future policy directions. So that's some of that background information in particular in terms of how all of this came about.
Thank you so much. So what were the key findings of all that literature that you reviewed?
Well, the literature review, again, that was a really important piece because that really sort of framed and shaped, the questions we decided to ask moving forward, and helped to really identify some of the themes, which I'll talk about in a few minutes. But what came out of the literature review in particular is that there were a number of things that had a specific impact. So the first was the health authority amalgamation. So again, as your listeners will know, we, previously operated under a system where there were a number of health regions. So the decision to amalgamate into one health authority, that happened in December of 2017. That really had a big impact. So, the goal of the government was, again, efficiencies. So the idea is that this would really help the system to be much more efficient, and that would be helpful in terms of not only costs, but in terms of service delivery. But what we were finding through a number of the news articles in particular was that, that wasn't exactly sort of shaping out to be what it was intended to be, especially in rural and remote communities. And that really came across clearly, during the key informant interviews and the World Cafe discussions. So the health authority amalgamation, that was, one of the big issues that came out of the that was identified through the literature review. Also, the closure of STC. So the closure of our provincial bus system, because of course, that just makes sense. Anyone who is from Saskatchewan and knows Saskatchewan knows how important that bus service was, especially to rural and remote communities. So it wasn't just about people being able to jump on the bus and travel to Saskatoon or Regina to see a specialist. That has a huge impact, of course, and we're still feeling the impact about that. But it's also about things like, again, lab results and all of that stuff that was transported through STC. Of course, no surprise to anyone, something else that really came through the literature review was the impact of COVID-19. So that impacted healthcare across the board, but certainly had really specific impacts in rural communities as well. And, I think we can all safely say that we're still dealing with those impacts, certainly. And the final really big factor that came through that literature review was virtual care. So there's certainly an emphasis, and part of that, I think, was heightened through the COVID-19 pandemic, but for other reasons. Certainly, we're looking at much more of an emphasis on virtual care, and I think many see this as the answer, and it certainly, I think, is something that will fill some gaps. But it's not fully the answer, right? There are still sort of impacts related to that. And not the least of which is the fact that we don't have really complete broadband access across the province. So folks in rural and remote communities, there are some places where you don't even have cell service, never mind internet service, right? For many years, the health and healthcare has been available through telehealth. But certainly there are other initiatives in place to make that more accessible so people can access health appointments without even having to go into a set telehealth center, right? So those are the findings that came out of the literature review.
So what are the major challenges impacting healthcare delivery in small Saskatchewan communities?
Well, I think, sort of building on that literature review and then taking a look at the service disruption data and the information we heard from folks that we interviewed for the project, in a nutshell, staffing shortages, service disruptions, access to transportation, and broadband access. Those are really the major challenges that are impacting healthcare delivery in small Saskatchewan communities. And, we identified through all of this data and information that we were able to gather in conversations that we had, we identified four main themes, and I think they're important. So the first theme is that the quality of rural healthcare really is at stake. And patients, ultimately, who are living in rural and remote communities, are really taking the burden of these existing systemic challenges and issues, right? So it's the patients themselves who are not able to always access the healthcare, not even, specialists, but primary healthcare services that they need. The second major theme that came across very clearly from folks that we talked with is that this one-size-fits-all sort of approach of the large health authority, so that amalgamation, has really created inequities in healthcare delivery for rural communities in particular. So that one-size-fits-all really isn't working. So folks we talked to who work in these rural centers in the healthcare system, talked about real delays in things like laundry, real issues in terms of decision making, real issues in terms of information sharing, and really feeling as though they no longer have a voice that they felt they had at one time. And that leads into the third theme, which was that health system care workers that we talked to are really experiencing an overwhelming sense of loss. So that includes, the loss of voice, feeling as though they're part of this system, a loss of morale. That really was something that folks talked about a lot. this loss of commitment to the health profession. So, you have folks who are not only committed to working within the healthcare system and serving their communities, but also sort of the larger healthcare system. And you hear them saying, I just don't think I can do it anymore. It's too much. I don't feel as though, the stress is too much. I don't feel that it's worth it. And overall confidence in rural healthcare. So, folks that we talked about really worrying about their own families and neighbors and being able to access healthcare. And then the final theme that came across is that healthcare really is the lifeblood of rural communities. And these recent changes in healthcare are impacting various aspects of communities. So not just the health center, not just health. When people are having to leave their communities, that has an impact on their communities overall.
So, what are the related social challenges to issues with healthcare outside of larger cities?
People, have raised money for years and years and years for their healthcare centers and their healthcare services. And so it brings a sense of fear, I think, and uncertainty when there's this realization that perhaps they're not going to have even primary healthcare services available in their communities. That's certainly an issue. And again, there's long historical political roots connected to that for sure. There is frustration. Residents are expressing frustration about these ongoing disruptions in services. And so, for example, where my elderly parents live, you don't even know if there's going to be emergency healthcare services available at the local health center until you drive up and see a paper taped to the door, right? Saying that there's no services available. So, again, it's all of those kinds of things. The other reality is that disparities in healthcare access in rural Saskatchewan really cut across racial and socioeconomic lines. So what we know is that lower access to adequate healthcare services is seen most often among poor and Indigenous residents. So these disparities, just seem to be increasing more and more. And I think, this is, in my mind, I think when we're talking about social impacts, what happens in rural communities, and in particular, what happens in communities connected to healthcare, has a direct impact on what's happening in medium-sized, large urban centers in terms of healthcare. So again, when people are having to travel to larger centers for healthcare access, and again, I'm not just talking about specialists. There are folks who are making the decision to travel for access for primary healthcare services, as well as, and I know this is going to connect directly to what Dave and Rebecca are going to be talking about, but also they are having to travel largely for services to support mental health, services for addictions treatment and support, right? So this has an effect in terms of what urban centers are seeing. Residents as well often are having to make the decision to move to larger urban centers because their health needs change, or they recognize or realize that they can't access the primary health care that they need. So then this has a direct impact, not only healthcare, housing, social, other social issues and factors. So there's an awful lot to consider. And whether we all like to admit it or not, we're all connected. Absolutely.
From the smallest villages to the largest cities, every day your urban municipality supports you. The water that travels from tap to sewer, the emergency services that keep you safe, the parks, libraries, and rinks that you enjoy. Our cities, towns, villages, resort villages, and northern municipalities are urban hubs bringing people together. We are urban. Celebrate your municipality as part of the urban family.
I'd now like to move the discussion to discuss mental health specifically. Dave and Rebecca, what are the key barriers for Saskatchewan residents in accessing mental health services?
I'm just going to jump in here. There's actually quite a few things that we could think of that are barriers. The first being that there aren't really enough staffing available even in this province. So, for example, even though we have in Regina, we have the urgent care center that's supposed to be 24/7 service. It can't do 24/7 service because there simply isn't enough staff in Regina or in this province to bring to Regina to do it that way. So even though the strategy is good and we have like the ideas of having more mental health staffing, the staff members just simply aren't available. So then you look at, if that's just at the urgent care centers, but when you look overall in the province at psychiatry, at psychiatrists and psych nursing and all of that, and nurse practitioners, there's not enough specific to mental health folks to take on the load of people who require those services. So that's one of the barriers, because then a lot of people are waiting for services when they need it the most, right? Another barrier is, so we have the urgent care centers in Regina and Saskatoon here in Saskatchewan, but when you look out of those two major cities to other areas and other even highly populated areas, those services don't exist there. So there's still a disconnect between like the more urban centers and the more rural urban folks external to those urban centers. And then if you look at transportation to get to those centers that do have those services, there isn't really anything available. There are some bus systems and stuff, but the hours are not necessarily great. And you have, so if you have an appointment, say, in Prince Albert and you live north of Prince Albert, it's very difficult to get to that appointment if it's whether it's counseling or a psychiatrist appointment or any of those types of things. So that's another barrier that happens, is like the transportation. And also when you look at it, one of the main parts of being in recovery when you have a mental health issue or you have a mental illness is most of the time you're not in a hospital, you're not in front of a doctor, you're in community. It's required that the community holds services, things like counseling, things like education pieces and that sort of thing. A lot of those things aren't funded appropriately or aren't funded at all. Counseling generally isn't funded. So if you have a job, you may have, 6 to 8 maximum is what I've heard of, counseling sessions that are available through your EFAP program. A lot of people with significant mental health issues don't have a job that has an EFAP program. So then the cost for counseling is very high, but the income that they have is very low. So then that makes that completely inaccessible. That's a problem throughout Canada, not just in Saskatchewan.
Yeah, so we've got models. We know what models are. We know how they work. We just got lots of problems in all areas, I'd say, in health, but mental health especially, perhaps, about having enough staff. And the transportation issue is really a major one, especially in remote areas and in the north. Yeah.
Okay. Well, thank you. So to build on that question, and you touched a bit about on how these issues are, across Canada, but are there Saskatchewan-specific contributors to poor mental health outcomes?
There are actually. First of all, I would like to, at this point, just say to everybody that we do have a nationwide survey and research project that collected data for I believe it was 2 years of data prior to releasing it just recently this past fall. In November, they released the state of mental health in Canada, but it broke everything down into provinces specifically. So which province is doing the best at this and which province is doing the less good or has more challenges and what those specific challenges are. And it went across Canada and did significant data collection on a number of topics. So I would actually suggest that anyone who's interested in this go to our national website. That's the CMHA National. If you Google that, you'll find it, and find that report, because it's very interesting where Saskatchewan sits in that space. So are there specifically Saskatchewan issues that come up that affect mental health? Well, one of the things that does affect mental health and wellness is isolation specifically. So if a person, say, has depression, and then they also feel isolated, that's going to exacerbate that depression and turn it into something more dangerous and more difficult to deal with and harder to medicate. And so we have found that throughout Saskatchewan, folks in more rural areas or isolated areas in the north and in the rural areas are more isolated from services, more isolated from people who are experiencing the same thing as them, and also find it easier to remove themselves from social functioning. So that in that way, we do tend to have a bit of a harder time with that in Saskatchewan than we do in other provinces, right?
Yeah, and I think a lot of that is Saskatchewan specific. We've got a very large province with a very small population. And so just the ability to have, what population, a larger population would be able to provide in a similar sized province is off the start not usually available, whether it's counselors or doctors or just equipment for diagnosis or whatever. It's very difficult to keep that up because we have such broad distances to travel and so on. So, I think that we have to say that both the federal and the provincial government have made some good strides forward with some funding for things, and we really want to acknowledge that. It's just that we've been so very far behind for so long that there's a very long way to go to have these kind of things adequate so that someone can get timely help. I mean, often we hear and see that somebody's in an emergent situation and really, really progressed a long way in some sort of illness before they can get help. And that shouldn't be it. It should be proactive and preventative as much as possible as it might be in a better provided, more populous kind of situation.
In the report that I alluded to, it also indicated that Saskatchewan uniquely has a high percentage of addictions issues. So for around the nation, Saskatchewan has probably the highest percentage of addiction issues. And we know that with the release of the most recent action plan that the government put out, and that was the Mental Health and Addictions Action Plan. What they did was they concentrated on addictions for that, and they have been working really hard to implement more treatment centers and more resources specific to addictions. But what's missing is prevention, like pre-treatment and post-treatment things. So when a person's ready to go into treatment, but they're waiting on a wait list, that's a high likelihood of relapse. So if they had connections to pre-treatment options, maybe even online or that sort of thing, there might be a way to prevent those relapses while they're waiting. And then also post-vention, because a lot of times people go into a treatment center outside of their home communities, and they learn stuff and they grow and they become fully excited about being clean about their sobriety. And then when they go back to the same situation with the same people in the same context, they end up it ends up being too difficult to hold on to that. So maintaining those connections that were developed during treatment is an important thing as well. So that post-treatment piece, which is also lacking in our province right now. So you end up seeing a lot of people going in and out, like a revolving door of treatment at this point.
Yeah, one of the things that happened during COVID was that a lot of the normal kind of rules and practices about doing diagnosis and even treatment, utilizing technology really was good. But then, there's all kinds of, well, can someone put in a request for payment if all they do is talk to somebody over Zoom or over Teams? During COVID, there was no question they could. After COVID, I think some of those things have gotten in the way again. And that's just really, really not appropriate in our mind for when someone has to travel 3 or more hours and there's virtually no way to get somewhere. It's infinitely better to do something from a small clinic in a rural community to a psychiatrist in a city by by Zoom or Teams or whatever. And in many ways, mental health is uniquely positioned with that. It's mostly listening to somebody, observing how they're doing, and doing a diagnosis that way. You don't need to have hands-on, kind of physical examinations necessarily. So we'd certainly like to see more of that be put in place and to streamline the payment and other kinds of things that could help with that. Because realistically, in our province, the way it's spread out so much with sparse populations, I don't believe it's ever going to get to the point where we've got adequate staffing and adequate equipment and everything else in every small community or northern community. This would really help until and unless we get that tackled in some way.
Interesting. And what you were just talking about is a good segue again to my next question, which is, wanting to understand more the link between mental health and substance misuse, and how they're linked, and your thoughts around that.
Well, there's a lot of significant links. I think there's a crossover of about 80% between addictions issues and mental health issues. A lot of times folks who have a propensity for an addiction, it stems from either trauma and trying to numb from that, or self-medicating because you feel like your thoughts aren't normal or they're not yours, or you don't want to admit that there's an issue, or just it feels good.
Yeah, you try to escape from depression or anxiety, and so it's sort of a self-medication thing in many ways.
Right, so that happens, and then we also know that there's a link going the other way, where there's like substances or like drug-induced psychosis happens. So in some cases, overuse of some drugs can cause chemical changes in your brain that don't change back, and then from that you end up with drug-induced psychosis, and that mimics or mirrors a lot of other mental illnesses that are out there, because it's basically this a very similar kind of thing with imbalances and whatnot. And so that can happen too. So then you end up with a long-term mental illness. And that's why that crossover is so high.
Yeah, and there's a really insidious thing that's very well known about the linkage between marijuana use and, in some people, not a high percentage, but high enough it's a problem, where it can trigger psychotic episodes. And if it triggers it often enough, those can become fairly frequent or even permanent. And so, that's just something that gets glossed over when we're talking about marijuana use, but it is very much an issue. I would say probably in 10% of people, there is that propensity built into their makeup that, allows that to happen or causes it to happen. And the other issue is there's still a lot of people that we're aware of that are using alcohol and marijuana. and possibly even using, prescription drugs at the same time. And this just kind of leads to a very unholy, very unhealthy mix, which again can really trigger some severe mental health or even health concerns.
And I imagine treatment gets far more complex when you have some of those factors at play.
Yes, it really does. Because in our society, we've somehow felt, marijuana is just a plant. I mean, it can't really hurt me, right? Yeah, well, so are most medications at one point just a plant, but they can certainly hurt you, right? So I think it's got to be an education thing, but I think with you to look at the demographics of sometimes younger people utilizing these things. I think we all know when we're younger, I can even remember that, you sort of feel invulnerable, right? And that can really lead to a lot of trouble.
Mm-hmm.
So one of the things also that becomes a barrier when you have a complex case like that is that our society and our government somehow at some point, and so our systems have decided that either you have a mental health issue or you have an addiction issue. And so if you go to try to get help with your mental health, with an illness that you feel you have, and you have an issue with substance use, then oftentimes people say, oh, no, you have to get treatment, you have to be clean before we can give you any mental health help. And then convexly, if you have an addictions treatment center or somewhere like that, they ask questions like, have you experienced suicide thoughts in the last 6 months? Because if you have, you can't come to our treatment center. You have to deal with your mental health issues. And also some of the medications that are offered as mental health medications are oftentimes also seen as potential addictive substances. So it can be difficult to navigate through and say, no, I need those. And I do need both. Like, so a person who comes to a place with a complex case of both a mental illness and a substance use issue will end up being passed back and forth, but not really getting the help that they need. So that can be a difficult thing too. A lot of people get stuck in that space.
Stuck and exhausted, I imagine.
Yes.
Yes. So we talked a little bit about Saskatchewan specific data and factors for mental health outcomes. I wanted to dive a bit deeper into some Saskatchewan factors. So what impact, if any, has the SED and SIS programs, so our income support programs, SED being the one designed for folks with, and I might say it incorrectly, but with disabilities. What has the impact of those two programs had on the work you do and mental health issues in Saskatchewan more broadly?
Yeah, well, I mean, the SED program, Saskatchewan Assured Income for Disability, has at its root a really good objective, which is raising the income of someone with a significant disability so that they can, live as a full citizen in our province. That was the vision and the goal. Unfortunately, like many things, it has not achieved that. And without many increases at all lately, each year it falls farther and farther behind. And so it certainly is better than it used to be under SAP. People are getting more. But, the idea that you would have enough to utilize the bus without having to get a special pass, you would have enough that you could go out and recreate with friends and go to some sports games or whatever, like most of us do. That you would be able to have a computer at home, like it's almost a given that we couldn't even live without a computer or even a good phone. Many people on SED cannot afford that. And same thing with where you live. I mean, we've tried to assist some people fairly recently on SED, and they're expected to find someplace that's $700 a month or less. And if they manage to get something that's a bit more that's approved, they have less for everything else, food and clothing and recreation and whatever. So the bottom line is it's not all about money, but it certainly is about the way that the minister that set up the task team that started said was that it should be a socially acceptable amount of money. And my position on that has always been on the task team and in the advisory group was we've already know what a socially accepted amount of money is for if it's an income replacement. It's minimum wage amount. And people are woefully below that. And so they're living in fairly bad poverty, some even abject poverty. And I'm just going to switch over to use the term determinants of mental health and determinants of health. And that just flows off the tongue for us in the field. But what it really means is, what are the kinds of things that determine whether you can live a healthy lifestyle or maintain your mental health? And that includes your housing. It includes your diet. It includes your ability to not be isolated and recreate. All the things that we recognized as we discussed what SED was supposed to be doing could bring a person up to that level of citizenship. And we've fallen off the boat with that right now, and we're hoping that we would get back on that. Now, CIS is a whole other thing. CIS is for people that are not, I want to say that SED is meant to be long-term unless your situation changes very dramatically for the better. It's a lifelong program, SED is. But CIS is the opposite. It's meant to give somebody a minimal amount of money so that they're kind of forced to go out and encouraged to go out and work. And for some group of people, that's probably reasonable. But there's a whole lot of people who've got all kinds of barriers and issues and hidden disability issues and so on, that just does not work. And they are forced to live in even a lower amount of money than on SED. And we also know that we at one point talked about there being what you'd call a SED light. In other words, you wouldn't get all the kinds of things that SED people got, but you would get enough because the disability or the barrier that the person has isn't quite enough to validate you and qualify you for SED, but it's still enough that you should be getting more support than CIS ever provides. So we have a long way to go to make CIS and SED both appropriate for what their original goals have been.
I want to link that back to your question about how that impacts mental health, right?
Mm-hmm.
And first of all, there are some mental illnesses that impact a person's life that is considered a disability by the definition of SED. So there are some folks, actually a good chunk of folks, who get SED because they have a mental illness and it's considered a disability. And it prevents them from working. And so that in that way, our like mental health is actually much like any other disability that prevents you from working, or mental illness rather, mental health issues. And it's long-term, it's enduring and significant like that. So then you have that impact, and then the things that Dave was saying about it not being enough to really cover the social determinants of mental health. But then also you have all the folks who are on SED who cannot quite make the stable food supply or decent housing that actually accommodates their needs, or transportation to recreational facilities, or the ability to recreate with friends and family members, and all of that. And that actually, the fact that people can't afford to do those things and can't participate that way impacts all of the people who are on those two programs is mental wellness, because they aren't fulfilling the social determinants of mental health.
Yeah, and one of the things that is really clear and research really shows is that when you have a significant and enduring disability, like people unsaid, you actually require more than a person without that to make ends meet and to do various things. It's more expensive for transportation. It's more expensive for for some people with all disabilities, not just mental health, but all the disabilities like clothing and assistive devices, and all those things cost more than your average person would have. But we've never really been able to, well, I think, to be honest, the amount that they said that it would be more is $70 a month. And that, when somebody's living in poverty anyway and probably has to use that money for food or replacing clothing or whatever, that's not very appropriate, and it's not near enough.
Can I pick at something else that Dave mentioned and just pull that, kind of expand on that a little bit? With regards to housing and how much people get for housing, that's an issue unto itself. But also, when there was a time when everybody's housing would be paid directly from the said worker, and that was erased for a few years. And people who are struggling to make ends meet sometimes make decisions to pay one thing over another, and people were missing their rent payments and being evicted. So they reinstituted that, but landlords are still a little leery to trust it. So even though we advocated for one of our friends here who came to us for help, we advocated for them to get housing, and they went to their said worker. They got a paper, like a letter, saying that the said worker would in fact ensure that it was paid directly from the said program and it wouldn't be in the hands of our friend. And so then what we did, so we got the letter and everything. We went and looked at studio apartments, which was the only thing that they could then afford, which meant going down some stairs, by the way. But the only thing they could afford were these studio apartments. And the landlords were saying that, well, this is more than a third of your income, so we can't rent this to you. So they were being declined and turned away from the only places that they could afford, according to the said worker, because they didn't fit this very specific criteria that the landlord created. And many landlords did that on purpose because they don't trust that the rent is going to be paid on time, because before it's happened before where people decided to remove that, and then people were lapsing on their payments.
Yeah. And the other thing that we found out, that they insist upon a person having a credit rating. And when you are living on $300 or $400 a month on top of your rent, you don't usually have much of a credit rating, and therefore it's a way for them to keep, once again, people out of even really inexpensive apartments, right?
Right.
So it's too bad that relationship between landlord and social services had been severed or fractured for that time, because people remember things for a very long time.
Well, thank you so much. And thank you for taking the time to join me today to discuss the barriers in accessing health services in Saskatchewan. Do you have any final comments you'd like to leave our listeners with today?
I always have a final comment that I like to leave listeners with, if that's fine.
Yes.
I just want to say that sometimes talking about mental health, talking about isolating, and if you heard anything in this that made you think, oh, maybe that's me, or maybe I've been thinking about things, or the neighbor down the way, maybe the isolation's getting him because I think he might be thinking of thoughts of suicide or something like that. Please call 988. There's some good people there to help. And who can link people with services and make sure that people stay safe. So let's take care of each other, like in all of our communities.
Again, just that this impacts all of us, and whatever we can do to be able to keep this at the forefront, and work collaboratively with our governments, local, municipal, urban governments, to be able to not have to be reactive, right? But to have good, solid policy and good, solid programs in place, I think is what's going to make the difference.
This brings us to the end of another episode of Municast. Thank you for listening in. In our next episode, SUMA's Director of Advocacy, Sean McKenzie, will be discussing the importance of libraries in our current social context and the challenges that they're facing with Praxis Consulting and the Regina Public Library. This episode, Reimagining Libraries, will be available on June 11th. Is your municipality a SUMA member? Did you know that elected officials and staff have access to resources, meeting and webinar recordings, templates, and more through the member portal? Each member municipality has one shared login to the portal. Chat with your administrator or contact the SUMA office for more information.